Hi, everybody. I'm Arno Kumigay, Vice Chair for Education for the Department of Medicine, and I have the privilege of launching this special citywide medical grand rounds. For this purpose, I'm actually going to turn it over to our newly appointed Vice Chair for Culture and Inclusion, Dr. Umber Najib. So Umber, please take over and introduce the speaker. Thank you.
Thank you very much. Good afternoon, everybody, and welcome here. It's an absolute privilege and honor to have Dr. Auguste here for this citywide grand rounds, which is named after a legend, Dr. Rossi. Dr. Rossi, as we know, was a pioneer and a stalwart in advocacy for greater Black representation in healthcare and in academic medicine. She worked out of Sick Kids Hospital and moved to Toronto in around 1980s. And in 1988, she became the first Black dean in Canada, serving as the associate dean at the University of Toronto. So paving the pathway for so many of us who are coming after her. She was the co-founder for the Association for the Advancement of Blacks in Health Sciences. She sadly passed in 2018, and I never had a pleasure of meeting her in person, but I've heard so much about her and read so much about her. And her contributions to medicine and academic medicine specifically lives on today. So we have these grand rounds specifically named after her, and every year we invite a trailblazer to deliver these rounds. Before I introduce Bourne, maybe I could start with the land acknowledgement as well. And this is what we have been trying to do in the Department of Medicine for some time, that we like to acknowledge the land on which we work, study, and live. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. Today, this land is home to many diverse First Nations, Inuit, and Métis people, and we are grateful to have the opportunity to live, work, and gather on these territories. And I personally believe, and Department of Medicine also believe, that land acknowledgements are only a starting point for larger conversations. We need to have more concrete actions for restitution, and transformation is needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First People and settlers. So this is a moment of reflection for us. How can we do individually and as an organization and as a department start the reconciliation with our Indigenous people? So without further ado, I would like to introduce Dr. Bourne Auguste to these rounds today. He is my colleague at Sunnybrook. He's a staff nephrologist. He's an assistant professor of medicine in the department. His job description is clinician in quality and innovation at the University of Toronto. He did his MD degree from McMaster University, and then internal medicine residency and nephrology fellowship at the University of Toronto. He followed this with advanced training in a clinical fellowship in home dialysis, and then a Master's of Science in System Leadership and Innovation from the Institute of Health Policy Management and Evaluation. He's currently the co-director for the certificate course out of the Center for Quality Improvement and Patient Safety. And I have the pleasure of working with him as a part of Culture and Inclusion team. He and Alana are the early career faculty lead representatives and are doing a lot of trailblazing work in that context as well. His main areas of interest are within the quality improvement with the focus on patient safety and equity. He's working on developing innovative tools to meet the needs of a diverse patient population with chronic kidney disease, particularly among those with an interest in pursuing home-based dialysis therapies. So thank you, Bourne, for coming to us and sharing your expertise and your knowledge with us. Over to you.
Thank you for the very warm introduction, and it's truly humbling to be invited today to give this talk, and it's nice to see some familiar faces here. So I'll get started, given that we have a lot to discuss today as it relates to kidney disease and disparities in kidney disease care. So the title of today's talk is Addressing Racial Disparities in Kidney Disease, Challenges as well as Possible Solutions. My conflicts of interest, I have received past speaking honoraria from Baxter, Healthcare, as well as Amgen. The main objectives for today's talk will center around to describe the burden of kidney disease in the Black population. We'll then move on to differentiate the impact of systemic racism and race-based medicine using clinical algorithms and its impact that it has on kidney disease care, and reflect on the individual practices to reduce implicit biases that lead to disparities in care. As was mentioned earlier, Dr. Rossi was a trailblazer in her own right, and it is truly an honor to give this talk today in her memory. Dr. Rossi was a pioneer and stalwart in advocacy for greater Black representation in healthcare. She worked as a pediatrician at the Hospital for Sick Children after having moved to Toronto back in the 1980s. In 1988, she became the first Black dean in Canada, serving as the associate dean at the University of Toronto. She also was a co-founder of ABBAS, which is the Association for the Advancement of Blacks in Health Sciences, and sadly passed away in 2018, but her memory and enduring contributions to medicine lives on today. Some of you might be curious about my journey and how it relates to my current philosophy and alignment of Black health, and which is the theme of today's talk. I was born in the Caribbean island of St. Lucia, a very small island that has very strong English and French colonial roots, which is somewhat the reason as to why my very first name is quite English and my last name, or my surname, is French. I immigrated to Canada back in 2004, and like many immigrants before me, came in search of a better life and more opportunities. My medical education journey began at McMaster University in Hamilton, Ontario. In a medical school class of over 170 students, I was about one of only 4 Black students in that class. After having completed my education at McMaster University, I went on to the University of Toronto, where I have done residency and training since then. However, there's always been this sense of whether I belonged, and would continue to get these questions about my sense of belonging and worth over the years. Questions commonly included, why did you come here? Where are you really from? Where did you actually do your training? And even more recently in clinical encounters where patients might ask me in independent practice, no, where did you do your training? Or what part of outside of Canada do you do your training? So I would always get these questions to question my validity or my sense of belonging to the society. I know that the experiences that I've had in my early career are also experiences by other Black healthcare providers. And this has been highlighted in a series in CMAG on Black health, where researchers in Nova Scotia reported similar experiences. I will say that much of my passion and interest in equity-focused care was not spurred by experiences of microaggression or subtle racism, but rather ignited by the glaring disparities in care that were seen in the heights and early stages of the COVID-19 pandemic. I forgot to mention at the beginning today, so if anybody has access to a smartphone and a computer, all of the cited articles today, you can be quickly scanned with a QR code and it'll take you directly to the article for additional reference if needed. So there's been numerous data, as I mentioned, from the COVID-19 pandemic that showed that the impact was quite significant, particularly amongst poorest and most racially diverse communities. This was primarily due to inequities in healthcare system, a disproportionate number of individuals who tended to work jobs that placed them at an increased risk of getting infected. The data, for example, as can be seen here, highlights an important fact that Black communities, as well as other racialized communities, make up a very small segment of the population in Toronto, roughly about 9%, but accounted for the majority of cases seen in the early stages of the pandemic. While one might think this was likely a Toronto-specific problem, but the data at the time revealed otherwise. Data published from Statistics Canada in 2020 demonstrated that racially diverse areas in Quebec experienced more COVID-19 related deaths than nearly all white centrist districts. In Montreal, the mortality rate was 149.3 deaths per 100,000 in areas with the highest percentages of Black Canadians, compared with 88.1 per 100,000 in areas with the lowest percentages. Then you might ask yourself, what exactly is driving this difference? It likely stems from undercurrents of systemic racism, which is important to get into. But let's first define race. Race is a social construct, system to allocate value or worth primarily based on phenotypic appearances. Racism exploits this system to give certain groups or individuals unfair advantages or disadvantages relative to another. Then you might ask the important question, and the thought-provoking question is, what is race actually measured? This graphic created by Dr. Mohotige, who is a nephrologist out of Duke, shows the broad factors that must be considered when we ask those questions around race. Given the cross-sectionality and implications that race might have in so many aspects of life, is there actually a structural basis to it? Systemic racism is not a new construct, but has persisted for years. It has continued even after the abolition of the transatlantic slave trade, Emancipation, and Civil Rights Act. Practices in society were meant to dehumanize people of African descent in all different aspects, ranging from the most basic human needs, such as access to water, housing, and even healthcare. These practices directly had health outcome implications, often leading to worse outcomes in marginalized groups. Some may say there is no such thing as systemic racism anymore. We've changed, the system has changed. Indeed, there have been changes where overt discriminatory practices are not as rampant anymore, but racism has become more covert and more difficult to appreciate. Racism might also intersect with other forms of different types of discriminatory practices in something that is actually termed intersectionality. What is intersectionality? Intersectionality was first put forward by Dr. Kimberly Crenshaw, highlighting the overlapping oppressions that African-American women face due to intersection. She highlighted a lawsuit that was brought against General Motors back in 1976 for discrimination against Black women. GM would hire Black people, would hire women, but not Black women. And at that time, it highlighted the close interaction of two domains of discrimination here that reinforce one another. It also proposes that various forms of social inequity stem from different layers of oppression. Some may say, well, this could never happen in healthcare. This was an isolated incident with GM. But I would point you to a study that was published in the New England Journal of Medicine back in 1999. This study had been reported and well described in the past. Actually, as a matter of fact, Dr. Wharton had referenced it last year in the talk dedicated to Dr. Rossi. And I think it's also worthwhile to review it once again. This study used a computerized survey instrument to assess physicians' recommendations for managing chest pain. Actors of different appearances and characteristics, seen here on the right of the slide, read a standard similar script describing their chest pain symptoms. 720 physicians completed the survey by reviewing the video recorded interviews. The key findings from the study was that men and white people were likely to be referred than women and Black people. A further examination of race and sex demonstrated something even more interesting in that Black women are less likely to be referred for cardiac catheterization. At the time, the authors postulated that biases may be due to overt prejudice or potentially subconscious biases in which cultural stereotypes in a provider's memory may be triggered, causing them to treat a particular group differently. Most people think that our behaviors tend to be driven by our conscious awareness. But as a matter of fact, most of what we do is formulated through our own learned experiences and the culture in which we were raised. This brings to light the concept of implicit bias. Implicit biases can affect the quality of care that patients receive. Contemporary healthcare providers, for the most part, and I would hope so, don't wake up every morning saying, I'm going to go to work today to do some harm to Black patients. Most healthcare workers want to do well by their patients. Healthcare providers are not exempt from these biases, which are usually associated with negative connotations and reflective of their own learned experiences for a culture in which they were raised. There is no intent to discriminate against a particular individual, and as a result, it is called unthinking discrimination. And this was eloquently put by a scholar and a leader in the field, Dr. David Williams, and he said this once in an IHI interview focusing on quality improvement of health equity, in which he stated, people with implicit biases are not bad people, but rather just reflecting the beliefs and cultures that they were raised in. Which also draws to an important point, that stressful and time-constrained environments can promote implicit biases. And we also experience that in the healthcare setting. One might argue that this is actually amplified in the healthcare setting. where there are enormous time constraints coupled with complex clinical scenarios and processes that people need to go through. So now that we've had a basic overview of biases and discriminatory practices within the healthcare system that may exist, let's examine its interaction and implications on chronic kidney disease care. So Black Canadians account for only about 4.1% of the total population, but amongst patients with CKD, they account for about 7.4% of that subgroup. I should point out that this prevalence is likely much higher in the province of Ontario, where a majority of Black Canadians currently reside. The higher prevalence of diabetes and hypertension within the Black population may play a significant role in the underlying CKD epidemiology. We must recognize that this epidemiology from the burden as cardiovascular disease and diabetes is important to recognize, as large observational data has shown that cardiovascular disease is a leading cause of death within the Black population in Canada. Social determinants are very likely to play an important role that drive this disparity at the moment. Beyond this imbalance as it relates to CKD is quite costly to the healthcare system. In Ontario, the health sector is one of our most costly sectors from an expenditure standpoint. Healthcare costs continue to rise, and with the expectation currently at the moment, $1 out of every $100 spent on healthcare goes to CKD or dialysis-related care. Cost for CKD services, including for those on dialysis and pre-dialysis, continues to rise steadily, and it may very well be close to $750 million within the next 3 to 5 years. So it's very important to consider the context in terms of the cost implications of untreated and unmanaged CKD on our society as well as our healthcare system. But beyond these costs related to the healthcare system, there should be an important recognition of the disparities that exist in kidney disease care. There's long been discussion about kidney disease disparities in the Black population, particularly in the United States. It was not until 1982 where a review in the New England Journal of Medicine brought to light the magnitude of these disparities. Roston and colleagues revealed that in Jefferson County in Alabama, Black people had an 18 times greater risk of developing end-stage kidney disease relative to white individuals. We sadly do not have this degree of granularity in terms of data here in Canada, but we have a general understanding of the CKD epidemiology that I highlighted in the previous slides. Well, some may say it might just be genetics driving the differences in disease prevalence, and that may be true to some extent. While there is some variation at the genetic level, it partly explains the differences in CKD prevalence. In nephrology, we know that apolipoprotein 1, also known as ApoL1, which is located on chromosome 22, plays an important role in underlying non-diabetic kidney disease pathology. About 13% of Black people in the US carry the ApoL1 gene. This ApoL1 gene, or the high-risk ApoL1 genotype, is associated with, as I mentioned, rapid progression of disease in some instances, particularly within the domain of non-diabetic kidney disease. West African ancestry, which is typically associated with ApoL1 variants, but there has been a broad generalization that all Black people with this high-risk variant may have it, and that is inherently flawed and should be avoided. For instance, Nigeria has one of the largest prevalence of ApoL1 mutations, as we can see here, but there are significant differences in prevalence across various ethnic groups within Nigeria, from the Yoruba to Igbo populations, accounting for broad heterogeneity within that population. Apart from genetic differences, which may play a limited role in underlying disease and disease progression, our environment can have such an enormous impact and influence on healthcare outcomes. For example, there are many important factors that contribute to overall health of our patients. Observational data has also shown that about 40% of health factors are driven by socioeconomic factors. Therefore, factors that influence socioeconomic factors can have an impact on health outcomes for patients. Let's draw on some important examples by directly examining some of these disparities at play here. And it really goes to show where you live really matters, and the impact that the environment can have on overall healthcare outcomes. This slide highlights an integral component that social determinants play and downstream impacts it can have on health outcomes. This data was published in 2007 from the Institute for Clinical Evaluative Sciences, demonstrated areas with low walkability within the city of Toronto, as well as areas with low opportunities for physical activity, which are usually associated with low-income housing areas and disproportionately occupied by Black populations. These areas are normally transected by highways, which make access to parks and walkability quite challenging. As the rates of diabetes and hypertension continues to rise, there's invariably an increased risk for CKD progression in these segments of the population. This, coupled with the aforementioned social determinants, can lead to rapid progression of disease. But sometimes we may overlook the pervasive nature that physiological stress might have on the body in terms of leading to pathophysiology, altered gene expression, and other factors. Even after a stressor may be reduced or eradicated, the concept of allostasis is an important consideration here. Allostasis is defined as a physiological response in the body in the presence of a stimulus to maintain some degree of homeostasis. That is why it's important to consider the transgenerational impact that racism may have on biology in an individual. This has also been highlighted and discussed in a review that was done in Nature's Review Nephrology about 2 years ago, where an increase in allostatic load or an allostatic overload may have downstream implications on kidney pathophysiology. The impact of allostatic overload is an area that still needs some further investigation in nephrology to truly delve into the transgenerational impact of stressors and how it can impact overall kidney pathophysiology. But at this point in time, we will just transition over into the impact that race-based medicine has in clinical practice. And sometimes there's a pursuit of precision over equality, is what I say. And unfortunately, the use of race correction in clinical algorithm has contributed to significant disparities in care. While some may say, may defend its use and as a means to individualize risk and guide clinical management, the inclusion of race in these algorithms, without a doubt, has propagated race-based medicine. As a matter of fact, several of these race-adjusted algorithms may guide clinical decisions in a way that tends to redirect resources to non-Black patients. So let's look at a few specific examples. Again, this can be scanned here, and in more detail is a lot more extensive list across different specialties. But here are the 3 ones I wanted to highlight here. So there's nephrology, there's endocrinology, and there's obstetric medicine. And this was published again back in 2020 in the New England Journal of Medicine. But for the purposes of brevity today, and for the purposes of this talk, we'll just focus on the eGFR. The precise measurement of the GFR, or the glomerular filtration rate, can be laborious, expensive, and not readily available in many settings. It is for this reason why practitioners need estimates of kidney function to inform practice around medication, dosing, diagnosis, and management of chronic kidney disease. The most commonly used approach to measure GFR, estimate GFR, had been the 2009 Chronic Kidney Disease Epidemiological Collaboration, also called CKD-EPI, and the 1999 modification of diet and renal disease study called the MDRD equation. Both of these equations apply a race multiplicative coefficient of 1.210 respectively, 1.210 and 1.159 respectively. These formulas were derived with direct measurements of kidney function based on iothalamate infusion and urinary clearance measurements, in combination with statistical modeling to create equations with race, gender, and age coefficients. The race coefficients were introduced to account for the differences that were observed in blood creatinine levels between Black and white individuals with similar measured GFR. So there has been some controversy around this in terms of what accounted for the differences. However, it is often assumed that the higher measured serum creatinine seen in Black persons is due to a more muscle mass. This thinking had been previously supported by older anthropometric studies. However, a closer scrutiny and analysis of these studies reveals some significant flaws in the overall design. And then you say, well, what's the focus of GFR? Why are we talking about it so much? The GFR is very important in terms of, as I mentioned, clinical practice, research, as well as implications for public health. We know that the kidney function has several other critical functions, but the focus on GFR is quite important to also determine clinical trial eligibility, as well as prognostication of CKD-related events. In order to assess the GFR, we typically use a variety of filtration markers, or we need filtration markers. Filtration markers can either be endogenous or exogenous. An ideal filtration marker should be excreted by the kidneys, not be protein bound, nor secreted or reabsorbed by the tubules. Given the aforementioned concerns about creatinine, there had been a renewed attention and a new focus and emphasis on a newer agent called cystatin C, a newer marker called cystatin C. And we'll just talk about this very briefly. Cystatin C is a non-glycosylated protein produced by all nucleated cells. It's much larger than creatinine at 13 kilodaltons. So that's roughly about 100 times the size of creatinine in terms of molecular weight. It's freely filtered, reabsorbed, and metabolized in the tubular cells. It's not influenced by muscle mass, and cystatin C is not excreted in the urine. So it sounds like a decent filtration marker. But there are some important drawbacks associated with it. Naturally, there are these drawbacks which center around malignancy, inflammation, as well as thyroid dysfunction and glucocorticoid use. There have been some small prospective case series which have shown that thyroid dysfunction has a major impact on cystatin C levels. Therefore, thyroid dysfunction has to be considered when cystatin C is used as a marker of kidney function. In contrast to creatinine concentration, cystatin C levels are lower in the hypothyroid state and higher in the hyperthyroid state as compared to the euthyroid state. So certainly some challenges around there. Beyond that, there's also the concern about costs. Cystatin C is not cheap in Ontario. There's currently a pilot project with the Ministry of Health and Alpha Labs where patients with OHIP get it covered at no additional cost. But if patients do not have insurance, it can actually, if it's not insured, it can be paid for about a price range of between $30 to $40. So we've talked about creatinine, we've talked about cystatin C and how it actually can have some challenges related to assessing filtration markers and estimated kidney function. So adjusting for the black race results in an increase of about 15 and 18% in the MDRD and CKD epi equations respectively. Researcher interpretations, particularly in the context of MDRD equation, may have not necessarily been what an individual self-identified as. Also, how do you factor individuals with parents of different ethnicities? How do we factor in people with different racial backgrounds? Do you assess the complexion of an individual or assess their hair texture to decide whether to include a race factor to estimate their kidney function? Clearly, this is not a scientific approach. Although at higher GFRs, the difference may be minor, but at lower GFRs, a difference between 5 to 10 milliliters per minute has significant implications on treatment pathways for individuals. A subtle overestimation or underestimation at lower filtration rates can have a significant impact for patients. Well, what do I mean by that? Let's have a quick look. Imagine two patients, similar age, weight, and height. They will have different clinical pathways solely on the basis of their appearance. This is an oversimplified algorithm, but the effects are broad. The effects are broad from the decisions about CKD referral, dialysis initiation, antibiotic, and drug dosage, to even decisions around the contrast imaging use. A lot of our care plans and algorithms stem from the GFR calculations. So we need to ask ourselves this important, provoking and rhetorical question to some extent: how did we really arrive at this point to have such disparities in care? And this culminated in 2020, where the NKF and the American Society, National Kidney Foundation, and American Society of Nephrology, ASN, formed a joint task force to address the use of the race factor in eGFR prediction equations. This came about as there was certainly an increase in awareness about some of the challenges related to coefficient use for being Black, as it was not necessarily leading to equitable outcomes in care. Accuracy apart, this has led to delayed care for many individuals in terms of referrals, and in some instances, decreased access to transplant. The transplant aspect is more so an issue in the United States than it is in Canada, but it actually brings to forefront some of the challenges related to the use of this race coefficients in equations. So there were two studies that were examined, that were done to examine the use of these equations and the overall implications, and if there could be any other alternatives at that time. First, the CRIC study, or the Chronic Renal Insufficiency Cohort Study, was a multi-center prospective observational study. Had about 1,400 patients enrolled, and what they did with these participants was that they got consent to collect data on race as reported by the participant, not presumed or assumed by the researchers, genetic ancestry markers, serum creatinine, serum cystatin, and 24-hour urine creatinine levels. In the second study here, which can also be scanned and looked up on the NEJM site, They used primarily old data sets, and the investigators relied on about 12 studies with about over 4,000 patients. Without going into too much extensive details, because these studies were quite long and extensive, we'll just go quickly to review the main conclusions from the studies. In the CRIG study, the use of serum cystatin C rather than serum creatinine for the GFR estimation produced estimates of similar validity while eliminating negative consequences of race-based approaches. So when race is excluded, the serum creatinine gives you a little bit less accurate information, was one thing that the authors concluded here in the study. But as I've indicated earlier in the talk, race is a social construct and has social determinants such as education, income, food security would have been important factors to adjust for in the equation, as they can certainly be confounders here, and that was not addressed. The second study showed that cystatin C provided a robust estimation of GFR and can be considered as an alternative to creatinine. Unfortunately, the existing data sets had way too many confounding variables to salvage to use creatinine as a reliable predictor for eGFR in this case. What was taken away from these two studies was that the task force came back and provided some recommendations. The first recommendation centered around adopting immediately the 2021 CKD-EPI creatinine equation that estimates kidney function without a race variable. And secondly, they recommended perhaps an increased use of cystatin C combined with creatinine as a confirmatory assessment of kidney function. So we have these changes to equations. Some people might say, yes, that's great. That's progress in the right way. But with changes, there could be downstream implications that we need to worry about in terms of care. And that was assessed in this nice review published in JAMA back in 2021, where they looked at data from the National Health and Nutrition Examination Survey, was used to compute CKD-EPI equations without the race variable for about 9,500 Black patients. Removing the race variable may increase the prevalence of CKD among Black adults from 14.9% to 18.4%. Additionally, 29.1% of Black adults with existing CKD may be suddenly reclassified as having more severe stages of disease. So we say, well, removal of the variable may overpredict risk, but we must be proactive to ensure that a group that has been historically marginalized is not suddenly told, hey, all along you had really bad CKD, we just didn't know it. Based on these new equations, things have changed quite significantly. And that can also foster and lead into a lot more mistrust with the population that has already felt disenfranchised in a lot of aspects of care. So that's one thing that needs to be appreciated. So what are some possible solutions that can be discussed, and what do we do moving forward? So let's talk about some policy changes that may occur. Over the last year, I've had the opportunity to work with various individuals across the country on finalizing some recommendations about the use of eGFR recommendations in clinical practice. We expect the final recommendations to be published very shortly, but they will likely align with some of the NKF ASN task force recommendations to perhaps just use CKD-EPI 2021 without the race variable and consider a combination of cystatin C and creatinine where available. But we need to recognize that new equations are not going to be the panacea and certainly eradicate equity gaps in CKD care. But it's a very important first step. This may serve as an opportune time to reassess this reliance on hard cutoff thresholds to determine treatment pathways for patients. CKD stages, and I know that might be controversial for some people, but CKD stages are in fact arbitrary thresholds, and practitioners as well as policymakers should definitely consider and think about it, whether a few milliliters per minute difference in eGFR has greater significance and impact on care than the development of overt albuminuria, poorly controlled diabetes, and poorly controlled hypertension. You cannot fix what you do not understand, and that's very important. We often jump into solutions without understanding the nature of the problem. And it is this rush to find the quickest solution that can often lead to the implementation of practices and policies that perpetuate the same things that we're trying to solve in the first place. I'm of the view that we need to collect race-based data. But in collecting that data, we need to be very particular, careful, and partnership with our communities. Partnerships with the Black community to highlight what the data is going to be used for. I know historically there's been reluctance to collect race-based data in Canada because there's always been this notion that there's no racism in Canada. Why are we collecting this data? Race is a social construct. It exists. So to understand the challenges of the disparities in care that people receive, you have to really go into the granularity of the data and the details of the data to understand the existent structure in which people currently live. So to pretend that it doesn't exist can actually be quite problematic and avoids addressing the problems head on. And it goes beyond simple virtue signaling and shows a commitment to the community that there's a genuine effort to make things better. As an example, I wanted to highlight a very interesting study that's been designed right now out of Johns Hopkins, which involves Black patients and examines the impact of DASH diet on hypertension and CKD. This study examines if dietary advice from a nutritional coach plus $30 a week worth of healthy foods will reduce urinary albumin excretion levels among low-income African Americans with hypertension and early-stage chronic kidney disease. The study will examine whether reductions in blood pressure could also be linked to improvements in diet. Hopefully, the results will help the Center for Health Equity offer informed decisions on educational approaches and policy initiatives. The study was initially intended to enroll about 150 patients, but I think the enrollment has just closed when I just reviewed the site recently, and I think they successfully enrolled about 140 odd patients. But again, it is collaborative efforts like this with researchers to examine some of the underlying issues as it relates to disparities in care is quite important, and how we can actually provide support to some of our more marginalized populations in addressing the underlying issues that lead to poor outcomes in care. And this was just a tweet that the Johns Hopkins Health Equity Group had put out, describing the partnership that they had with some local grocery stores to allow for purchase of some healthy foods within that environment. Additionally, there are some policy changes that could happen from the renal network perspective and the ORN. So historically, policy recommendations have been made without engagement of people that will be impacted by the policy. Right? This has led to a plethora of ivory tower policies, for lack of a better term, that are disconnected with the reality on the ground. It is therefore important to foster stronger working relationships and collaborations with community partners in crafting policy. So over the last few months, I've had the opportunity to work with the ORN in a limited capacity in the early consultancy stages of developing the ORP4 or the Ontario Renal Plan 4. That will place a greater focus on health equity in Ontario. Simply put, for people who are not familiar, the ORP, the Ontario Renal Plan, is like the strategic blueprint of how kidney disease care is rendered in the province. And it's currently in its third iteration, and the fourth iteration is expected to be launched next year. As part of this early consultant stage, engagement with the Black Physicians Association of Ontario, along with the Black Health Alliance, has been initiated. For those not familiar, the Black Health Alliance is a community-led registered charity working group aimed to improve the well-being of Black communities in Canada. From a local level, a divisional level, we've also fostered some relationships with the Black Health Alliance. And over the last 18 months, I've had the opportunity to work with them in developing workshops for our trainees as well as faculty within the Division of Nephrology on equity-based care that align with various themes within nephrology. We entered a memorandum of understanding with the Black Health Alliance in 2020 to co-develop educational content and workshops around those themes. Tianda Fonte-Coleman, who has spearheaded a lot of the work related to the development of these workshops, is a researcher at BHA and currently a PhD student, and her work currently focuses on the Pathways to Care research project as well. We are in the process at the moment of finalizing a manuscript that speaks to the challenges and opportunities that lie ahead when you develop and design some of these workshops, particularly as it relates to addressing some of the education equity within our division of nephrology. Importantly, I think there's also a recognition at the individual level, and I hopefully that speaks to most attendees here today, but we must appreciate that we have biases. Biases exist. I did the implicit bias test and I was shocked, right? It's in my subconscious. It's like, okay, wow. You'd be surprised. So I would challenge most of you here today to just do it. Just do it. People become defensive and say that you can't be biased, but again, it's in your subconscious. It's unthinking discrimination. You don't actively think about doing harm or being biased to somebody. And it has been influences by experiences from your upbringing and your environment. Different types of biases exist, and common ones in medical practice typically include attribution bias. Something bad happened to a patient, so it's their fault, right? Confirmation bias is an inclination to draw conclusions about a situation or person based on your beliefs and your desires, and rather than an unbiased merit. So for example, this patient likely got CKD because they didn't come to their appointments, but it doesn't go into the reason why the patients didn't come to the appointments. Perhaps they had 2 jobs. Perhaps they couldn't get sick day off to come to the appointment or do the blood work. Well, maybe they can't afford the SGLT2 inhibitor that you try to put them on and they have rampant proteinuria. So to say this patient didn't come to the clinic or didn't take their meds because they deserved it, they have CKD, and that's part of the way that we just simplify our thinking and not necessarily going into the minutia of the things that lead to poor outcomes for some of our patients. So I tend to rely on this sometimes to understand ways in which we can address the issues, because it's a complex process. The socioecological model can be used to truly understand some of the fundamentals of inequities in health. Much of the model was actually derived from work done by Broff and Brenner back in the 1970s, but parallels can be certainly drawn to see various levels in which care can be impacted. At the individual level, at the interpersonal level, organizational, community, and public policy. Public policy such as law, governing norms, and practices in society can have a profound impact, and one would argue the largest impact on addressing inequities in health. So I'll leave you with this to think about this for a second. And this was quite striking when I read this piece in the Scientific American, published about just under 4 years ago. And it says this: one reason people on both the right and left are skeptical of implicit bias might be pretty simple. It isn't nice to think that we aren't very nice. It would be comforting to conclude, when we don't consciously entertain impure intentions, that all of our intentions are pure. Unfortunately, we can't conclude that. Many of us are more biased than we realize. And that is an important cause of injustice, whether you know it or not. And that is true on so many levels. As I said, we don't go about the majority of us don't go about to want to do bad by people, and we become defensive because we want to believe that we're nice people, right? So it's important to recognize that implicit biases exist. That's what I want to get across. So quick take-home points. Black population in Canada, as well as in the US and North America, is disproportionately affected by CKD. And there are multifactorial drivers for this discrepancy, which range from social determinants. Genetic variations may have a role to play in it, but most of the factors are driven by disparities in socioeconomic factors. Removing race-based factors from equations is a start, but as I mentioned, it's not a panacea. So we can't just take the equations away from the race algorithm from equations and walk away and say, okay, our work's done, let's get back to something else. It's more than that. This is tiresome on many levels. I recognize that, I appreciate it. But just removing a race-corrected factor is not going to close the equity gap. It needs a lot more fervor and a lot more committed work to address some of these issues around equity. Solutions demand multifaceted approach, as I highlighted here, at the individual level, by looking at your own personal biases and recognizing that subconscious biases do exist. Community partnerships, engaging people who you're going to implement policy for at the table, have discussions with them at the table, as well as engaging in your local environment, whether it be your division, your Department of Medicine, in your local environment, to liaise with those partnerships and to have some important connected stakeholders to address some of these issues. And lastly, people who set policy, the ORN, recommendations from a guideline perspective, the CSM. These institutions and organizations have a significant impact on overall how we practice our care from day-to-day perspective. And in turn, that will actually have likely the largest impact beyond the other things we're doing to address some of the equity gaps in care that have been offered for patients. At this point in time, I'd like to acknowledge a lot of my allies, collaborators, and mentors who've done a lot of work, mentors both formal and informal, and who have given me an important compass to stay committed to doing this work. Some of it can be at times frustrating, tiring, but you have to remain committed because it's not easy to address some of these issues. So I'd like to acknowledge some of them here today. And once again, I'd like to thank the organizers for inviting me here today to speak to this issue, and I'm happy to take any questions or continue the discussion. Thank you so much.
Thank you so much. Wow. I think what an amazing, amazing talk, Bourne, which I think has given us a lot of opportunity to reflect upon who we are as a person and as a professional. And if you allow me to make two statements, thank you for highlighting bias, because I still hear rumblings about department has all become implicit bias testing. And I fully acknowledge that implicit bias tests are not perfect, but it's human to have bias. If any one of us think we don't have bias, that's an incorrect statement. And eyes cannot see what the mind doesn't know, one of my late professor used to say. So all these tools and all these implicit bias testing make us aware about our own personal biases so that we can be reflective and reflexive as humans, as professionals, as clinicians, as teachers and educators. So I'll open up for any questions or any comments from the audience. You can type it in the chat, or you can unmute yourself and ask the question. And I see a hand, Bruce Perkins.
Yeah, hi, Ambreen. Thanks. Bourne, I agree. That was an amazing talk. Congratulations. Thank you for taking the time to do this. A brief comment and then a weird question, I guess. So the brief comment is that it amazes me around the type of bias we're talking about. The EGFR between races is actually a measurement bias or measurement error. And it amazes me that we haven't committed to just the simple diagnostic validity studies, a gold standard inulin or iothalamate measure on one race with a spectrum of GFRs, and then on another race and another race with the same spectrum of GFRs, and that they're directly compared. It seems, I know it's tough and it requires money and time, but it seems like an extremely important question. So that's the first comment. Like, I understand when we're, there's this sort of confounding issue if a population is more likely to have kidney disease. What we want to know is, when it's directly measured, what's the measurement error? And it amazes me that we haven't really done those studies. So you can comment on that if you know of others, but I'm just amazed by that. And then my question's the weird one. I trained here in Toronto a little while ago, and, my mentors, like people like Wayne, I apologize if I'm misquoting you, Wayne, but generally the idea was that if we were to mention in rounds on a case report, someone's race, it had to have a reason. I was concerned about something on a differential where race would be important. Whereas when I trained later in the US, it was understood that every history we would mention race. And I understand that to round, we don't have to mention race each time. We could still collect it and it be in our information data system without talking about it. And I'm just curious about your opinion. Should race always be discussed, or should it just be measured? And I hope you understand the question and don't think that it's too weird.
No, not weird at all. Thank you for that question, and thank you for being honest about that. It's in the NKF recommendations, that the full one that was published, and it was recommended that moving forward prospectively with the identification of newer filtration markers such as cystatin C, that a more concerted effort is done to identify and diversify the population and engagement in terms of validity studies moving forward, to really actually try to improve the precision of future measurements. So I think there is a concerted effort to try to improve the accuracy of some of the future filtration markers. That can be lauded, but I think some of the other factors are also important to consider, particularly as it relates around the social determinants of care. And its impact for individuals. I think from your second part of your comment as it relates to race, and as I mentioned, race is there. It's a construct that exists within our society, whether or not we like it or not. It's present. I think it's important to actually measure the impact that it's having on overall outcomes of care. I think if it's just used for non-informatory purposes, or not to actually designed to improve overall outcomes for individual, then perhaps it has no merit. But I think if it's designed in such a way to understand the nuances in terms of how people might have disparities in care, that's one way to collect it. And that's why I say we can't just go around just collecting race data without engagement with community partners in terms of what that data is being used for. I'm not sure if that kind of addresses your comments or speak to some of your questions. in detail, but I'm happy to chat offline if you have some time.
So,
That's great, thanks.
Bourne, we have a question in the chat. In the majority Black population countries in Africa or the Caribbean, is the risk of chronic kidney disease the same per capita as it is in Canada or United States?
That's a very good question. One would say actually a little bit higher, and for a variety of reasons. The mistrust of the medical system is not something that is unique to North America. You know, I am from the Caribbean, and there is also a cultural perspective of sometimes not wanting to go to the doctor, not really sure what people want to say, or you know, having the appropriate follow-up. So it's multifaceted in that approach. So I wanted to be clear that this experience is not unique, essentially can actually transcend different cultures and different experiences around the world. So rates of prevalence for sure are also high, because there's also challenges in equity in terms of access to medications in some of these countries. You know, if I were to go down to St. Lucia and ask how many people on an SGLT2 inhibitor, I would imagine it's a lot, because it's probably might be very costly. So some of these things are also part of the reason why the predominance and prevalence of disease is high, or even higher in these cases, because the access is even a lot more diminished for a variety of reasons.
There's another question in the chat, and then we go to the raised hand as well. Are there any other medical tests which factors the race variable, like the way you gave an example of equation to us?
Yes.
To us?
There is a Net Nejam article that I referenced by VS and colleagues, published in 2020, had about, I think, 15 or so. There's one for cardiology. I didn't pick on all specialties today, but almost each specialty has one. There's one for cardiology in terms of the AHA guidelines in terms of managing a patient with heart failure. There is obstetrics in terms of, that's another big one, using VBAC surgery, vaginal birth after cesarean section, where patients who are Black have a factor that is added into the equation where it reduces their, it affects their risk score. And as a result, these patients are not commonly offered a trial of a label in instances. There's also the FRAX tool for my endocrinology colleagues are in here, that actually has a race factor that has been embedded into the equation, which is used in the US sometimes. And that in turn is sometimes stemmed from a history where people believe, oh, well, Black people have stronger and bigger bones. And as a result of that, they may be delayed access to osteoporosis care and timely medications and intervention. So there's a list of them. That article by VS is a good reference point that people can review.
Dr. Wharton, you raised your hand.
Terrific talk, Bourne. This was amazing. So I have
nice to see you, Sean.
I have a question and a comment to Bruce. Bruce, and in places where the race as a social construct is a major issue, and therefore there's social differences with the individuals, and mentioning race makes a difference. So doing some during your presentation, so doing some educational work in the States. If you're in Baltimore and you don't mention the person's Black, it makes a difference. If you're in South Africa, you don't mention Black versus white, it makes a difference, because it's access to medications, it's what the risk factors are, et cetera, et cetera. If you're in a place where there's truly no difference in race in terms of the social construct, they're treated similarly, there's no economic differences, then mentioning race doesn't really factor in. But it would be a misstep to not mention race if you were in South Africa doing a presentation, because it confers a lot of different aspects about the patient. So that's where a lot of the challenges are. But I have the similar questions to you, Bruce, about that you had about now that we've changed the if we're going to change the actual equation, Bourne, and we see that now, initially we thought we were underestimating the EGFR, and now we're going to, maybe we're overestimating it, but is it truly an overestimation, or is it just an accurate estimation? Yes, they've moved from potential renal failure to severe renal failure, or is that true? Is it documented with macroalbuminuria or other factors, or that show that that those are accurate numbers? So are we being thrown off, or is it actually okay?
Yep, very, very good point. So with the revisions, there is, in some instances, there'd be an overestimation, but the magnitude of that change is not as significant as the existing disparity right now in terms of the current CKD-EPI equation. So what will happen is that yes, there'd be a reclassification, and that's where I think important education with community partners in terms of launching these new equations is so important. Because if you all of a sudden, as I said, if you suddenly have people saying, well, suddenly I have stage 4 CKD, and last week I was told I had stage 3 CKD, was this missed? And that will actually foster more mistrust. So I think what we need to emphasize for our patients that these are estimates. These are estimates. Sometimes we just use the point estimate. Oh, this is your kidney function. This is where you are. These are estimates. And I think it's important to actually track them on a more serial basis to provide more guidance on how we actually offer management to them. And it includes other things as well in terms of albuminuria levels, blood pressure control, diabetes control. But these are estimates. We're estimating roughly about where your kidney function might be. It may be a little bit above there, a little bit below there. Because some of the studies actually showed that in terms of the P30, in terms of how much of the data actually aligned with the estimate with measurement, was about 85% of patients had a 30% accuracy within the measured GFR. So I think we just have to have that nuanced type conversation with our patients and be honest about that these are just estimates.
Great. And I think that if that is going to be the issue, is that we have to have an educational conversation with them. But I'm more on the side of getting rid of the race-based equations and having the number be the number, and then having to deal with what that number actually means from a educational standpoint to the patient and to others, that this number still is an estimate. So we need to look at other factors. But I'm not putting an equation on you because I don't know what your genetics really are. How much white do you have in you? How much Asian do you have in you? What are your true genetics? I don't know, but I know this equation shows such and such, and we will work on figuring out other aspects of whether you truly do have kidney dysfunction or not. So for many of the equations, the respiratory equations, the cardiac equations, which are all flawed.
Martin, I'm going to interrupt you. It's almost time. There's one last question which I wanted Bourne to comment upon, which has been waiting in the chat. Like, how do you counter implicit biases to start dialysis or other clinical decisions are made? There are two examples, a white patient with a creatinine of 1,000 and a black patient with a creatinine of 2,000. And that will be the last question for this afternoon. I'm sorry if I ignored any hand in the interest of time.
I'm just trying to, is that question in the chat from Dr. Prasad? I'm just trying to read it here.
Yeah, Dr. Prasad.
I didn't know that could identify like. So I think and thank you, Dr. Prasad, for that question. I think it's a complicated question and it's a complicated issue. I think one of the issues that we typically need to have with these patients is that we need to have an understanding of what the history is, and sometimes we have to spend a little bit more time with the patients. I know it's a busy and stressful environment, but understanding the nuances in terms of how somebody got to where they are, how they ended up in the emergency department with a particular illness, and not presuming, oh, this patient's black, they didn't take the meds, they have diabetes. Well, diagnosis closure, this is it. This is just a routine and course of your life, rather than actually investigating what are some of the challenges there. Because if these challenges that led to the kidney disease in the first place and the need for dialysis are prevalent, they'll remain prevalent issues while they're on dialysis, which will also complicate the quality of care that they receive. Their access to transplant later on, their ability to attend appointments or attend things. So that needs to be explored sometimes in a little bit more greater detail. It's easier said than done given the constraints in our current healthcare system, but I think we should afford them the opportunity to understand in a little bit more detail, and rather than just rely on biases for simplicity and expediency purposes.
So thank you so much. It's almost 1:01. We are 1 minute over time, but what a wonderful talk, which gave us a lot of food for thought to reflect upon and to be reflexive around our own biases, how they are impacting us as clinicians, as teachers and educators, and how can we make a difference. And I want to say one more thing. Bourne said something about belonging. We are all in it together, and we need to enhance inclusive practices so that we can belong and we can flourish in the Department of Medicine and in the University of Toronto. So thank you very much. There are a lot of compliments in the chat, Bourne, and there are a lot of well wishes and also wishes to work with you in future as well. So I just wanted to pass that on to you as well. So thank you very much again.
Thanks for the invitation. Thanks, everyone.